All right, so welcome everybody to the Ran podcast. This is the first podcast that we have. My name is Connor Hamilton. I'm a second-year emergency medicine resident at OHSU in Portland, Oregon, and I have an interest in critical care. I'm interviewing Dr. Ran here. I'll let him introduce himself.
Hey guys, I'm Ran. I'm an intensivist and I also work in the ER, and I'm staying around in academic medicine because I love learning with these guys, and these cases are a great way to learn that.
So just to talk about some of the goal of these videos and this podcast is discuss topics in emergency medicine and critical care. We'll be going through a semi-case-based format from presentation in the emergency department to care in the ICU and kind of the full gamut of what happens with those presentations. One of the things that we will be doing is kind of deviating from the case to talk about specific situations. When I've worked with Ran in the ED, one of his philosophies that he mentions is to always be worried about the worst thing that can happen. And if you know what the worst thing that can happen and how to address it, you'll be well prepared. So we kind of taken some deviations from the case to talk about those things.
I don't think there is a really good clinical pathological case conference format for resuscitationists or emergency physicians. The CPC for internal medicine is really a diagnostic dilemma, right? Like you kind of stand there, you ask the audience, you present the case to the audience, and the audience will ask questions of you, and at the end of the case, you reach a diagnosis. In the ER, that's probably the less exciting part. The more exciting part is you have a time crunch to find out what is or isn't wrong, and once you've found it, what are you going to do next, and what are you going to do with all the permutations of things that are going to go wrong or could go wrong with this emergent scenario. So that's why I like doing this, and I look forward to what challenging case you have for me today.
All right, so let's jump into our first case. This is just a 69-year-old male. They have a history of hypertension. Reportedly, it's well controlled on lisinopril. Maybe they have type 2 diabetes. They come to the ED by EMS with sudden onset of tearing chest pain that goes through to the back. Started about 30 minutes before he got into the ED. In the ED, he arrives with a blood pressure of 170/95, his heart rate 90, setting 97% on room air. He's afebrile. So what is your initial thought process when you hear this story? Obviously, it's somewhat classic for aortic dissection, but what is kind of going through your mind?
Chest pain is hard because it really could be anything.
Yeah.
We're trained to think about the worst case scenarios, but probability-wise, a lot of times it turns out to be nothing, and that's fine. In the ER, the difficulty is to figure out what hat I'm wearing because the ER physician wears many different hats, one of which is a resuscitationist, and I usually start with that one. Does this patient need active resuscitation? And the things that make me determine that is when there's a vital sign that is incompatible with life. Then that's when you put on the resuscitation hat because you're not even going to look for another problem until you fix that. In this particular scenario, there are no such vital sign abnormalities. This person, though they're screaming in pain and they have a concerning complaint, is stable. The next question I ask myself is, what are the chances that something really bad is going to happen to this person if it's not already happening? So that's a diagnostician hat. And that's the hat that I'm probably putting on at this point, in which I'm thinking about not per se the most common reason for why this person has chest pain, which is usually not emergent, but the most dangerous reasons for which this person has a chest pain. Same things always come up, and we're trained to think about this in ER all the time. It's just drilled in you. Is it an aortic dissection? Is it a PE? Is it an MI? Those are the three big bad ones. Or is it Boerhaave if there's a lot of vomiting right before that? The quality that it's tearing makes you think more that it is dissection. When it's sharp or tearing, you think more dissection or PE. When it's more of a pressure, you think more that it is MI, though there are obviously many exceptions to this rule, but the clinical history always means something, despite all the studies that say it doesn't.
Okay. So I think you mentioned those, like really what you look for on history is this like sudden onset tearing chest pain or sharp chest pain. Are there other things you're going to try to gather from the patient that is going to push you down the road towards trying to diagnose aortic dissection?
Yeah. History and physical is always where you start. I think the emphasis has shifted away from that, but I'm more old school. I really think you should do everything you can from the history and physical side of things, everything you can with your hands. One of the things I like to do is while I'm getting the history, which should in this case really dive into a family history, you really worry in the patients with Marfan's or Ehlers-Danlos. But while I'm talking to them, just switch the blood pressure cuff around. Do that while you're talking to them so it costs you no time. I like to check the blood pressure. on at least two extremities, if not also on the leg. And that just gives you an immense amount of data for how the plumbing system is currently functioning. It doesn't rule out an aortic dissection, but it does rule out critical limb ischemia from aortic dissection, which is what makes aortic dissection complicated versus uncomplicated and can completely change your management.
Yeah, so what does a patient need to say, or what do you need to see to actually do that blood pressure measurement in both arms? Because that's a question I always have to attendings and people who've been practicing a while. Is like, what actually pushes you to do that? Is it just the story the patient's telling you, or something you see, vital signs?
For me, every time I see a vital sign that's abnormal, the first thing I do is question the measurement. And so in this case, the hypertension is not emergent, but it's certainly catching my eye. And the same thing is true with hypotension. If the person was hyper or hypotensive, and in the back of my head I'm thinking about treating it, I would first confirm the measuring device was accurate. And the way I confirm that is look at the size of the cuff, look at where it's positioned on the arm, is there a sweater underneath the cuff, and then switch it to the other arm to get corroborating evidence. So my threshold for switching arms is very, very low. Okay. Because personally, I'm a tinkerer. I like to mess with my measuring devices anyways, and that's usually one of the first things I go after.
Okay. That makes sense. And then do you check bilateral radial pulses to see if there's a pulse deficit, or do you just kind of go with the blood pressure?
I actually check pulses probably more than most people. There's a couple reasons I do that. One, you can figure out the heart rhythm almost immediately just by the pulse. Two, finding tamponade is really finding a good pulse and doing a good pulse exam, because the pulsus paradoxus, which is how we're taught to find tamponade, actually described originally not a blood pressure drop with respiration, but a pulse deficit during respiration. When they breathe in, the pulse goes away, and when they breathe out, the pulse comes back, and that's a regularly irregular pulse. You only find that by really taking your time and feeling for it. I like finding people's pulse because it gives me a sense of, if things were to really go downhill, I know what your baseline is, and I know where your pulse is, and I would know whether the blood pressure reading of 70/30 on the next check is real or not, because the presence or absence of your radial pulse.
Okay. So just to kind of summarize some of that stuff, it sounds like somebody comes in with a chest pain, and if we're thinking about aortic dissection, low threshold to check bilateral blood pressures, low threshold to feel radial pulses, get a good history and physical, and kind of go from there. In taking a history and physical and thinking about diagnosing aortic dissection, there's often this talk about likelihood ratios, and there's these tables with likelihood ratios. Some of the ones I have here are basically like tearing, ripping chest pain, giving a 10 times likelihood ratio for aortic dissection, migrating pain, focal neurologic deficit, diastolic heart murmur. Those all are positive likelihood ratios. Is that something you actually think about when you're looking at a patient? And like, do you think about these likelihood ratios, or is it more just like clinical reasoning and gestalt you're going off of?
Yeah, so the likelihood ratio derives from a system of logic called Bayesian logic, and that is a way to try and justify or understand how we are thinking. So that's a way for us to understand what the clinical gestalt is, and to assign a number to it. I think most people's clinical gestalt can actually be relatively accurately described by this type of logic. And the reason why this is because there is no test in medicine where if it's positive, it's definitely true, and if it's negative, it's definitely not true. Everything modifies your suspicion one way or another. And sometimes the most satisfying cases are the ones where you are so certain, for reasons you can't fully understand, that something is true, and the initial test was negative, but you dig deeper, and then you find it. Our tests, based on the fact that there's different degrees of invasiveness to each test, are inherently flawed in one way or another. Do I memorize the likelihood ratios? Never. But does it make sense that someone who comes in with tearing chest pain, who's elderly or has Marfan, so your pretest probability is high, so you're very suspicious, and they have a neurological deficit, makes you so much more certain that this is dissection? Absolutely. That makes rational sense. The thing that's tricky about the likelihood ratio stuff, though, is that there's a difference when you're thinking about a disease as a whole, i.e. as a conglomeration of many different patients representing that one disease, And when you're thinking about the patient who's being afflicted by a disease, so now you're thinking about an individual, how generalizable is population-based medicine to the individual sitting in front of you? Very debatable. Ultimately, we're treating the person in front of us, in which case these likelihood ratios don't mean nearly as much as they would for describing a population of people representing a disease.
That makes sense. So it sounds like you kind of use them in the back of your mind. Obviously, you don't memorize them, but that is kind of the idea and logic behind them plays out in your practice quite a bit.
Yeah.
Okay. Before you've seen this patient, you've got like the accurate blood pressure measurements. It's elevated in both arms. Are you going to do any initial steps to kind of stabilize and resuscitate this patient that's sitting in front of you? Are you going to give them, what are you going to give them for pain control? Are you going to give them aspirin given they have chest pain? What are your thoughts about that?
From a vital standpoint, the patient doesn't need any emergent resuscitation yet, not till you figure out the problem. It's actually dangerous, I think, to treat hypertension when you don't know fully why or prove that the hypertension is in and of itself harmful. You want to think about pain and anxiety management as a tool for taking care of the patient, and someone who is combative, who you can't get an exam on, who is really just writhing and not, it's influencing even how you take your measurement on the blood pressure, for example, because their arm is tensed up. The pain management is valid. It's helping you take care of the patient in addition to relieving their symptoms. But the person who's texting and saying they have 11 out of 10 chest pain, probably not. As for the aspirin and all those things, the thing is with MIs is that too is in a huge umbrella term. And more the push has been to try and better delineate that term. Because right now we're kind of throwing it at everybody.
Yeah.
And the more sensitive the troponin gets as a test, the more D-dimer it becomes. Where MI, the push has really been to differentiate it from myocardial injury versus myocardial infarction. And even with, if you call it a myocardial infarction, you'd have to think, is this acute plaque rupture or is this from something else?
Yeah.
Antiplatelets and antithrombotics only benefit that former category of myocardial infarction from plaque rupture. There's a lot of things that will raise your troponin, and there's a lot of things that give you chest pain that will have no benefit and possibly harm through antiplatelet or anticoagulation. Granted, aspirin is probably the least harmful med you can use. Now, if you did aspirin, Plavix, and heparin when they have a dissection, that's probably a huge deal. But it really speaks to trying to figure out what's going on with a history and physical before you leave the room and assigning a probability in your head that this is more likely to be an MI based on the EKG and story, or this is more likely not to be, and maybe I should wait and just figure things out before going forward.
Before diving into any specific treatment for them.
Yeah.
So let's say the patient, you walk out of the room. I think the workup for this patient isn't super complicated, the one we have in front of us. Obviously, correct me if I'm wrong, but getting a CBC, a CMP, maybe getting coags, getting an EKG, getting a troponin, getting a chest x-ray. But with this specific patient that has this tearing chest pain, what's going to push you to pull the trigger for a CTA? And this one's a pretty good story, but other things in your mind that's going to push you down that route to actually pull the trigger and get a CTA of the chest?
Yeah, I mean, if the dissection is very high on your differential, then you should just go for it. Granted, some of the quicker things like a portable chest x-ray probably wouldn't get in the way of the CTA, so I'd probably just get that first. Yeah. Just in case it's a pneumothorax, though it's very low likelihood based on the story. The other element of it is if it's not the first thing on your differential, it might be the fifth thing, but you worked your way through it and the rest of them are not positive or you don't think it is, then ultimately you'll still land on the CTA at some point. And this happens at our institution in ED-Obs where, you admit them for chest pain, NSTEMI, MI workup, and it doesn't smell right, doesn't seem right, and then they move towards CTA, and sometimes they catch it that way.
Okay. The other thing I think you mentioned already I wanted to bring up is a D-dimer in the setting of aortic dissection. I think D-dimers in anything is very controversial, and I wanted to know what your thoughts about this was, specifically for dissection.
Yeah. D-dimer, the literature on it is interesting, but it's not terribly robust.
Yeah.
Almost all the studies are retrospective, and they don't have huge numbers because dissections are not that common.
Yeah.
And no one's thinking about getting a D-dimer when they know they have a dissection, because usually it's a panic to do all these other things.
Yeah.
The data that is available suggests that the sensitivity of D-dimer is very, very high, which makes it a good rule-out test, because the negative likelihood ratio, therefore, is pretty good. The problem is, though, that it really depends, because the problem with how medicine is taught about these tests is it's a positive or a negative, but the reality is most test results is somewhere in between. And you kind of want to think about it as a 3-compartment model rather than a 2-compartment model. So, I mean, in certain patient populations where, for example, you're trying to convince the patient they don't have a dissection, it might be valid.
Yeah.
Especially if the patient can buy into, yeah, I'll take the D-dimer instead of the CT scan, sure.
Yeah.
But as for diagnosis purposes, it's not that helpful. It's not going to tell you what it is.
Yeah. Okay.
And the other problem is, too, is aortic dissection, like I told you, is an umbrella term, right? Is it going to pick up a penetrating ulcer? Probably not. Is it going to pick up an intramural hematoma, which is sometimes a precursor to a dissection? Probably not. Not if there's no communication to the rest of the blood system, because usually those things are contained.
Yeah.
So the pathophysiology of this actually makes a difference.
Okay. So let's say, moving along in the case, you order that workup that we talked about. They're getting a portable chest x-ray. They got an EKG. It's going to be a little bit before they go to the CT scanner. You throw an ultrasound probe on the patient. What are you looking for specifically for helping you diagnose dissection? How often, do you use ultrasound when you're concerned about aortic dissection? Have you ever picked up a dissection actually on ultrasound? What are your thoughts about that?
I think my use of ultrasounds, if I was to describe it, as a trainee, I used it a lot, and I justify that because I wanted to learn.
Mm-hmm.
But the further out I've gotten from that, actually, the less I've tended to use it. And it's not because it's not helpful. It's just that in terms of bang for its buck, it hasn't, in my opinion, been all that game-changing. And the reason why is, even if you found a dissection on ultrasound, you're still going to need the CT.
Right.
There's no way you're avoiding this test, because you need to know, how far does it go back? How far does it go down? Is it a type 1, type 2, type 3? Where is the penetrating ulcer? All these questions that you just can't answer with ultrasound. And even if you didn't see it on ultrasound, that would not persuade you from getting the CTA, because the negative predictive value of ultrasound is actually really low. So I encourage everyone to learn it, just because you'll never be sorry for having more tools in your toolbox, but it might not be a tool that you use that frequently. I do use ultrasound a lot if I can't find the pulse. And this happens actually a lot. You start to appreciate how difficult it is to find the pulse once you really earnestly start looking for it, especially in vasculopathic patients, who are the ones who are most likely to be afflicted by aortic dissection. And that's when ultrasound is super helpful. I ultrasound the artery, I put flow through it, color through it, and basically do a really quick bedside arterial duplex to confirm that I couldn't feel the pulse because I couldn't feel it versus it's not actually there.
Okay. Actually, I'd never thought about doing that. That's interesting.